This is the AAC guidelines for LV systolic function, and it's a fairly comprehensive document. And so I'm gonna try my best to go over most of the stuff. So what they said was the quantification of cardiac chamber size and function is the cornerstone of cardiac imaging, with echocardiography being the most commonly used non-invasive modality because of its unique ability to provide real-time images of the beating heart, combined with its availability and portability. Standardization of the methodology used to quantify cardiac chambers is maintained by creating and disseminating official recommendations, which, when followed by practitioners, provide uniformity and facilitate communication. This is the document that everybody involved in echo needs to follow. Most places around the world follow the AAC. The recommendation for echocardiography chamber quantification were last published in the 2005 by the American Society of Echo and the European Association of Echocardiography. So this is a little bit more updated. Okay. Since the 2005 document, echo technology has continued to evolve, with the two major developments being real-time three-dimensional echo. So three-dimensional echo is fairly standard in some institution now, and not only three-dimensional echo, but myocardial deformation imaging, and this is what we call the strain rate and velocity. So a lot of institutions are doing strain evaluation. Okay, so these are some new developments in echo. So the goal of the guidelines is to provide an update to the previously published guidelines. And they're going to give you some normal values for, you know, the changes that were made. Now, all measurement described in the document should be performed on more than one cardiac cycle to account for interbeat variability. So, you know, what the suggestion is, if the patient is in sinus rhythm, you do 3 beats, okay? When you evaluate in any structure, I mean, if it's normal, you want a minimum of 3 beats. And if the patient is in, say, atrial fibrillation, then you do 5 beats. If it's a normal study, it don't make any sense you do, you know, an excessive amount of beats. 3 beats is sufficient to evaluate structure. However, if you think there's abnormality and you want to spend a little bit more time, so you take whatever time you need so that you can get the answer you're looking for. Okay, so again, this is testable. All right, so if you're going to do, say, patient have mitral stenosis and you're looking at the mitral inflow and say you want to do pressure half time, patient is in atrial fibrillation, you need to do a minimum of 5 beats and average them. Okay, if the patient is in sinus rhythm, you can do 3. So the measurement of the LV size, you know, so these are stuff that should be routinely done. The most commonly used parameter to describe LV cavity size include linear, internal dimensions, and volumes. So when, you know, we usually start with parasternal long axis view, and we do certain measurements. That is standard. And then, we do volumetric analysis, and we usually do volumetric analysis in apical 4 and 2 chambers as well. So measurements are commonly reported for end diastole and end systole. So we need to see how big the heart is in diastole, because one of the indication that the heart, something is wrong with the heart, is the size. If the size is very large in diastole, then you may have a problem. Also, end systole, if the heart is not able to pump sufficient blood out, the end systolic dimension is going to be significant. Okay, and we index a lot of our stuff. As a matter of fact, in this current report, a lot of measurements are indexed. And when you index the measurement, you divide by the body surface area. So let's look at some of the linear measurements. So it is recommended that linear internal measurements of the left ventricle and its walls be performed in the parasternal long axis view. The value should be carefully obtained perpendicular to LV long axis. LV long axis. So these are not arbitrary measurements. I'll show you what they mean by the LV long axis, and your measurement should be perpendicular to that. You're going to do your measurement at or immediately below the level of the mitral valve leaflet tips. Okay. In this regard, the electronic caliper should be positioned to the interface between the myocardial wall and the cavity, and the interface between the wall and the pericardium. So basically, you're measuring from one extent to, if say you're measuring the septum, from the uppermost portion of the septum to the lowermost. For the posterior wall, you're going to do the same thing. Internal dimensions can be obtained with a two-dimensional echo, or you can do two-dimensional echo-guided M-mode measurement. So you can do M-mode measurement, but it should be two-dimensional echo-guided. Okay? You want to make sure that your measurements are perpendicular. What about volumetric measurements? So we do linear measurements, and we also do volumetric measurement, measure volumes. LV volumes are measured using, we can use two-dimensional echo or three-dimensional echo. Volume calculation derived from linear measurements may be inaccurate. So we used to do volume calculations from linear measurements. We don't do that anymore. It is really not recommended, but for historical significance, you can know a little bit about it. But we don't do it because it's usually inaccurate. So I've shown you the quinone, the modified quinone method and all those things. So it's not really recommended. Now, when we're doing our measurements and we're using M mode, it should be two-dimensional guided. So you see your two-dimensional echo on top, and you're gonna this is your cursor. Your cursor should be perpendicular to the structure, and it should, let me show you. When I say the LV long axis plane, this is what we mean. So you say the LV, this is the septum, this is the posterior wall, the LV moves in this direction. So this is the LV plane. The LV plane will be something looking like this. Okay? It's in the middle of the LV, and it's parallel to the septum and the posterior wall. So this is the LV plane we're talking about. So your cursor, your measurement should be perpendicular to this, 90 degrees. Okay? So this is your cursor right here. You can see, so it's perpendicular. Okay, you want to be at the tip of the mitral leaflet, and then you can do your measurements. So measurement, you measure in the septum. Your measurement should be at the onset of the QRS, and then people doing the exam, you're going to get that. You're definitely going to get it. So the measurements, so you're measuring the septum. Okay, this is the onset of the QRS right there. So the septal thickness from the top down to the bottom, septal thickness, LV cavity size in diastole. This yellow line represents that from the cavity to the tissue plane. You come down, you make a perpendicular, you come straight down. So this is the LV cavity size in diastole, and then the posterior wall from right there down to the bottom right there. Okay, at the onset of the QRS. So you get your systolic measurement, your diastolic measurement, and the posterior wall. Okay, and then they didn't show you the systolic measurement, but at the lowest point, you're going to drop a perpendicular down, and you come straight down, and then this will be your systolic measurement. Okay. Usually, as you know, diastole is the most is the widest diameter. Systole should be the smallest diameter. So the advantage of this is reproducible, high temporal resolution because it's using M mode, and a wealth of published data. This has been around a long time. And then these are some of the limitations. Beam orientation frequently off axis as a single dimension. So, but you can use the M mode if it's two-dimensional guided, and you can just go straight to your 2D. If you're gonna use your 2D, then again, the tip of the mitral leaflet, as we said before, the LV plane. So you're going to be perpendicular to the LV plane, and then the LV plane is this line. This is parallel to your, so the LV plane is going to move in this direction. Okay, it's going to be parallel to your septum, posterior wall, and then this should be perpendicular to it. Okay. And then this is the tip of the mitral leaflet. So you measure your septum. Again, onset of the QRS. So the septum, the LV cavity size, and diastole, the posterior wall. If you should always have an ECG on your imaging. If you don't have an ECG, however, then you get the largest diameter, that should be diastole, and then the smallest diameter, that should be systole, where you should always try to get an ECG on board. All right, so when we talk about volumetric assessment now, so what is recommended, you can use your 4-chamber view, or you can use a 2-chamber view. If you're going to use the 4-chamber view, then your apical 4-chamber, and you're going to plane the endocardial border in diastole, so end diastole, and you're not going to see some people that curve around the trabeculation and stuff. No, you don't do that. You just cut straight around, okay, and you come to this point, okay, and you do the same thing. You come to this point, and then the computer will join the 2 points. So this is the mitral valve plane, and then this length from the midpoint here to the furthest, the most distal point in the apex. So that is your diastolic measurement. Then the systolic measurement, you do the same thing. You start at one point of the mitral valve, and you come You don't go around the clavicle, you go straight through the trabeculation, come down, and you stop here. The computer will complete that. So you get your end diastolic volume and you get your end systolic volume. The computer will give you ejection fraction. And the same thing for the apical two-chamber view, diastole and systole. So volume measurements are usually based on tracings of the blood tissue interface. Okay, the blood is right here, the tissue is right there. In the apical 4 and 2 chamber view at the mitral valve level, okay, the contour is closed by connecting the two opposite sections of the mitral ring with a straight line. So the computer automatically, once you have a point here and a point there, the computer close that thing. The LV length is defined as the distance between the middle of this line, so the middle of the line, and the most distant point of the LV contour. Okay, so all right, so that is ejection fraction. All right. Now, the method that you use, so people doing exams, again, it is the method of the biplane disk summation, or the modified Simpson's rule. Okay, they have an area length method. That's not the recommended that's not the recommended quantification method that the AAC use. It's the biplane method of disk, or the modified Simpson rule. So what it does, it cuts the LV cavity in these in disk, in small disk, and it sums them up. Okay. So it corrects for shape distortion. There's less geometrical assumption compared with linear dimensions. It's fairly accurate. However, you can get apex foreshortening. So the apex is frequent foreshortening. So you have to be constantly looking, because you will foreshorten the apex. All right. You can get endocardial dropout as well. If the endocardial border is not well defined, you can use microbubble contrast, and you should use it generously. So you inject microbubbles, and it gives the cavity a white contrast, and you can see the endocardial border, so you can accurately do planimetry of the border and get your ejection fraction. We, as mentioned before, strain has become very, very popular, and we use it quite a bit. We'll go over what strain is, but basically strain is just a change in the length. We use the Lagrangian strain. The formula for that is you can say LT minus L naught over L naught, which LT is you can call it the instantaneous length, or the length at some period of time, minus L naught, which is the original length, divided by the original length. And these are what we call deformation parameters, because when the heart contracts, the heart shortens in the longitudinal plane. So what usually happens, the base moves up towards the apex in systole, and then in diastole it moves down. So if you were to use the diastolic measurement as the original length, and then when it contracts, it shortens, and you use the systolic dimension as the instantaneous length, you can see you'll get a negative number. So we use peak strain, and we use two-dimensional speckle tracking derived strain, and we'll look at that. But what we do is, so this is the LV wall, and we divide the LV wall into segments. So that is how we look at the heart. We divide the heart into segments, and if we have the apical four-chamber view here, we have the basal segment, we have the mid segment, and the apical segment. And then again, apical, mid, and basal. So we would give each segment a strain value, basically seeing if each segment shortens to the extent that it should. And the percent shortening should be roughly about 20%. But because of the formula, it's going to be negative number. So a normal strain should be roughly about negative 20. Okay, you can see these are, this is negative 14. So it's a little bit abnormal. Negative 16, probably a little bit abnormal. But you look at the strain, you do strain analysis for the different segment. And then when you put it on the curve, okay, you're going to put it on the curve, and it's color coded. So each segment has a different color. So you want to make sure that you get to that minus 20. That means it should deform, it should shorten by about 20%. But because it's shortening, that's why it's negative. If you were looking at the heart in the short axis, when the heart contracts, it thickens. So because it thickens, when it contracts, that would be a positive number. We'll go over that. But again, when you look at the strain curve, there are a number of things that you can look at the peak strain, see if it's abnormal, and you can look at peak strain to see if all the curves peak at the same time. Because when we did dysynchrony, remember, one of the way you can look at dysynchrony is if the peak of the curves occur at different points. When the heart contracts, in order for the heart to be very efficient, all the segments should contract at the same time. If the segments are contracting at different times, then the heart is not going to be efficient as a pump. And you can see some of these peaks are not at the same time, but that's not what we did. When we do strain using speckle tracking echo, what we do, okay, you can do strain using Doppler. Remember, the problem with Doppler, it's angle dependent, and so as a result of that, sometimes it is inaccurate. When we do speckle tracking echo, we look at the different speckles, and what we call speckle is those varying shades of gray. And if you remember from ultrasound physics, those varying shades of gray is basically interference. You can have constructive interference and destructive interference. When you have constructive interference, it's look bright, and destructive interference looks dark. But you're following the speckles, so it is not the it's not a Doppler method. You look at the speckles, and those are you track the speckles. So that's how we do. So LV volume should be measured from the apical 4 and 2 chamber views. Two-dimensional echo image acquisition should aim to maximize the LV areas while avoiding foreshortening of the left ventricle, which can result in underestimation. Because of the issue of foreshortening, because the issue of foreshortening is less relevant when you do three-dimensional echo. If you have the ability to do it and you're comfortable in doing three-dimensional echo, then that's what you should use. But if you're not trained to do it, don't just do it for doing its sake, because you have to know what you're doing. And then contrast agent should be used. So again, people doing the exam, they're going to have, this is the indication for contrast. Contrast agents should be used when needed to improve endocardial delineation when two or more contiguous LV endocardial segments are poorly visualized in apical views as per published guidelines. So this is exactly what they're going to ask you. What is the indication? So when you need to improve the endocardial delineation when two or more contiguous LV endocardial segments are poorly visualized, then you use your contrast. Okay? And contrast enhanced images may provide larger volumes than the unenhanced volumes. So as mentioned before, the most commonly used method for two-dimensional echo volume calculation is the biplane method of disk summation or the modified Simpson rules. Again, people do an exam, that's another question. Okay. So one of the advantages of your three-dimensional echo volume measurement is that they do not rely on geometric assumptions. Whenever, if there's any question and it has to do with volume and they have three-dimensional echo, that is the right answer. Okay. So three-dimensional echo gives you superior volume analysis. So the recommendations, the AC recommend that LV size should be routinely assessed on two-dimensional echo by calculating volumes using the biplane method of disk summation. This is what the AC recommends. In labs with experience in three-dimensional echo, three-dimensional measurement and reporting of LV volume is recommended when feasible, depending on image quality. So those are the recommendations. So when you're reporting LV volume using linear dimensions, the recommended method is 2D guided measurements, okay? And the LV size and the volume should be indexed, okay? So this is what is recommended now. So you have to know what's recommended. When you reporting on the LV size and the volume, it should be indexed. So whatever value you get, you're going to divide it by the body surface area. So the normal end-diastolic volume, left ventricular end-diastolic volume for males is about 74 mLs per meter square. Normal left ventricular end-diastolic volume. And for females, about 61 mLs per meter squared. And then the systolic, the end systolic volume for male is 31 mLs per meter squared. And for females, about 24 mLs per meter squared. So they want you to index these things. So this is what is recommended. So what I recommend, people doing echoes, you need to follow the AC guidelines, and especially people doing exams. If you follow the AC guidelines, then you don't have to try and remember anything. You just have to remember how you do your studies. Okay. So when you're doing, your say you're doing your ejection fraction, you usually look at your end diastolic volume and your end systolic volume, and then you do your analysis. Just what we have mentioned. So let's look at this table because these are some new data. Okay, so these are some normal values for two-dimensional echo for LV size and function. And let's look at the LV. So these are linear measurements. So these are linear measurements. So this is your parasternal long axis view. And when we talk about your diastolic dimension in males, so 42 to 58 millimeters, okay? So up to 58 millimeters is still normal. For females, it's 37.8 to 5.2. So I recommend that you use a chart because the values for male and female differs. So once you get accustomed to the chart, then you don't have to use it. So this is the diastolic dimension. Systolic dimension for male is 25 to 39.8 millimeters, and for females, 21.6 to 34.8. So, and then the volumes, you can familiarize yourself with the volumes. But another important thing is the ejection fraction. Ejection fraction. So the range for males is 52 to 72%, and for females, 54 to 74%. So if you remember 52 to 74%, then you'll get everything. Okay? But there's a slight difference in the range for males and females for ejection fraction. So again, you should put up this chart and use it. Again, your ejection fraction is end diastolic volume minus end systolic volume divided by the end diastolic volume. And the computer will do the rest for you. All right, so let's stop here, and then our next session we will go a little bit more into strain, because I suspect that those of you who were not exposed to strain before probably going to have some difficulties, but it's not a difficult concept.